Good afternoon, evening, morning, wherever you are, everyone, and welcome to what I believe will be one of the most important conversations about the future of reproductive medicine that we'll have this year. I'm Steve Klasko. I've spent my career as an obstetrician navigating the intersection of healthcare innovation, policy, and economics. I led Jefferson Health through a $10 billion transformation to now working with great startups like Oova that are replacing how we think about care delivery. But I've never seen a field as ripe for disruption and contradiction as fertility medicine in 2025. Here's where we stand. Just 3 months ago, President Trump signed an executive order promising to make IVF dramatically more affordable for American families. Good news. That same week, 125 House members were supporting legislation that could effectively ban the procedure. We have AI that can predict embryo viability better than human embryologists, yet patients in 14 states are worried their frozen embryos might legally be considered children. Major employers are offering unprecedented fertility benefits while Congress debates cutting $880 billion from health spending. These aren't abstract policy debates. They're affecting real families right now. And they're creating a landscape where innovation is racing ahead of regulation, where economics is colliding with ideology, and where the promise of democratized fertility care is bumping against harsh realities. And tonight we have the absolutely perfect panel to unpack these contradictions and maybe even a few solutions. We have the clinical expertise, the advocacy voice, the technology vision, and the economic reality check we need to understand where fertility medicine is heading, not just where we hope it's going, but where it's really going. I'll just briefly introduce the panel members, and then what I'd ask you each to do when I ask you a question, please spend a minute doing a much better job than I would do in introducing you. So we have Dr. Amy Divaraniya, the founder and CEO of Oova. We have Barbara Collura, the president and CEO of Resolve, the National Fertility Association. We have Dr. Kimberly Thornton, one of the country's premier reproductive endocrinologists from RMA of New York. And we have Samantha DiMercurio, employee benefits from Marsh McLennan and a board member and VP of membership, as well as a podcast host for the Society of HR Managers. Wow. So let's start with the biggest question hanging over this entire field. And Barbara, you look like you're ready. So I'm going to start with you after you introduce yourself. President Trump campaigned on making IVF free for all Americans. His executive order asked for policy recommendations, but it doesn't really offer the funding mechanism. Big surprise.
Mhm.
Meanwhile, universal coverage would cost roughly, I think, about $8 billion annually, while the administration wants to cut health spending by almost $900 million. So, as Resolve's leader, are you seeing this as real healthcare policy, like make America fertile again, or just another Maha goal?
Well, hi. Thank you, Dr. Klasko, so much. My name is Barb Collura, and as you said, I'm the president and CEO of Resolve, the National Infertility Association. We're a nonprofit patient advocacy organization. Resolve has been around for over 50 years. It was founded in 1974, and we help people here in the United States navigate their family building journey, whether that's through emotional support, patient education, public awareness, or advocacy, which is what we're talking about tonight. We do a lot of policy work at the state and federal level. I've been the president and CEO for 18 years and just a minute. And my husband and I, we went through our own infertility journey. My son is 25, almost 25, so it was a while ago. But I think you're asking a question that's very difficult to answer because I would need to get into the brain of our president, and I'm not sure that I can do that. But you're right. There's a lot of actions that seem very diametrically opposed and not all the same, moving in the same direction. So I can see why you asked the question. I can also see why there's a lot of confusion. In terms of the executive order, you rightly said he made this promise on the campaign trail to make IVF free or your insurance will pay for it. So I'd love to know where you got that figure for what it would cost to see everyone in the United States get IVF coverage, because that is what we strive for. That is what we are aiming for. Look, we all have medical emergencies. We all have things that we need to have done medically. I mean, we all have family members. My mom's had a knee replacement. My sister had a breast cancer. All of these things were covered by their health insurance. And they didn't go into medical debt for them. And thankfully, they had the coverage and they were able to get the care that they needed to live a full life. I believe that infertility care should be treated the same. So instead of us putting a number on, here's what it's going to cost to add this, I think we talk about where do we as a country see family building, and quite honestly, treating our reproductive system as part of healthcare.
Yeah, let me just follow up on that for 1 second because I think you brought up a really good point. This is not about infertility, it's about women's health. It's about health.
Men's health and men's health.
And yeah, yeah, and for any president, who wants, and whether it's a Democrat or Republican that believes in family building, that believes in health, what you're basically saying, this shouldn't be a separate thing.
Correct.
It's going to cost somebody something, right? If United Healthcare is going to cover everybody, that's going to cost them something. If government funding is going to cover, it's going to cost them something. The number doesn't matter, right? Just like you're saying, well, how much does cancer care cost? Is that sort of what you're saying?
This is not an industry. This is healthcare. We're talking about our reproductive systems. We're talking about therapies that and honestly bypass what's not working, and where there's therapies that help propel our reproductive systems to work. In some cases, you've got a same-sex couple, you've got a single woman, you've got somebody without a uterus, you've got, as I like to say, you need sperm, egg, and uterus. You've got one of those three that's or more that's not working or not functioning. How do we, as a country, help you to get to the goal of reproduction and an attempt at pregnancy? And that's what we want to see covered, that whole spectrum.
Okay, that's great. So, Dr. Thornton, let's assume for a minute that Barbara is the Secretary of HHS, and this all comes to pass. The executive order, exactly as we'd like it to be, comes to pass. Could you talk a little bit about what would actually change in your practice if that were to happen versus what happens if it doesn't? And also introduce yourself a little bit, please.
Sure. So I'm Dr. Kimberly Thornton. I'm a reproductive endocrinologist and infertility specialist. I work at infertility practice in New York City called RMA of New York, where I have been for 9 years now. And so I treat people who are doing fertility preservation as well as infertility, as well as things like Barb mentioned, like same-sex couples for family building. So we see it all. And I think if it passes where people truly have access to care and access to IVF, it's going to be huge for patients. I feel very privileged that I live in New York and it is a mandated state. So there is a huge portion of my patients that have insurance coverage, but it's still not even enough in New York in a mandated states because there's too many loopholes. There's too many patients for small businesses that don't require, there's federal employees. I have military families that don't have insurance coverage, or if their main location of that company is in, let's say, Texas, and they're in the New York branch, they don't necessarily meet the mandate. So there are a lot of patients who still don't have access to care. And I think as fertility physicians, we only see this as a positive thing because there are more patients that need fertility treatment than have access to it or that can afford it. And so it would truly be game changing. There's really very other fields in medicines where if someone has a disease, because infertility is a disease, where treatment is not covered. And even certain diseases like endometriosis that causes infertility, well, insurances will almost always cover for that person to have a laparoscopy or surgery for endometriosis. So I don't know, it's very confusing and mind-boggling that it won't cover the infertility aspect. And so it is a little bit hypocritical that these things aren't covered. And so I think we'll see more people enter care because a lot of people just don't because they don't have the access or resources to be able to do these treatments.
Dr. Thorne, you bring up a really good point. I'm a generalist OB/GYN, and you talk about endometriosis. If I code endometriosis and do a laparoscopy, and we don't really have any even good proof that doing a laparoscopy for pelvic pain and endometriosis is necessarily helping, but that will absolutely be covered. Could you maybe just go through, because I think in my practice that people that were going through infertility treatment, you know, literally in some cases that was worse to at least the family than a cancer or heart diagnosis as far as how it affected the person, the woman, the family. Could you just talk a little bit about that, the difference of knowing that IVF, which is now so effective, for example, would be covered?
I mean, all the data and studies show that people going through infertility treatment have the same level of stress, anxiety, and depression as those going through cancer treatment. So what you're saying is definitely correct. I think the statistics are about 75% of patients with infertility have anxiety, and it's a little bit over half with depression. So from a mental health standpoint of view, it definitely takes a large toll. And, I always tell patients, everybody has their emotional, their physical, and financial limits of what they can put themselves through. So you can emotionally burn out, you can financially burn out if you go through your resources, or physically, meaning your body. And any of those burnouts can lead to somebody not being successful when they might have been if their cup had kind of stayed full, meaning if they had the access to treatment where they could afford it, they may have not been emotionally or physically burned out, and then they could have had success. But the same is true. You can have all the financial resources, but if you emotionally burn out, I see patients every day who stop treatment that would most likely go on to be successful because of that emotional burden that the treatment, that infertility takes on not just the female, but the male partner as well.
All right, so Samantha, now it's on you. We have Barbara as the Secretary of HHS mandating fertility in our dream world. We have Dr. Thornton that continues to improve technology, looking at things that are much better as far as IVF and other treatments. You advise employers across all 50 states. Are we sort of in a country where your zip code determines your reproductive options?
Mhm.
No pressure, right? Dr. Klasko, thank you for that. Samantha DiMercurio, employee benefits consultant for Marsh McLennan Agency. And you are correct. I do advise employers who are based in all 50 states and who have employees either remote or physical in all 50 states. It's a complex answer. Fertility benefits in today's landscape and world are so state mandated in terms of their offering and and size, what size the employer is. I wish I had a magic wand and say, yes, everyone has care and treatment. My job is to, one, educate the employer on what's available, two, ensure that their employees know what's available, and then three, provide creative options to ensure that their employees have the coverage that they desire. To Dr. Thornton's point, if an employee doesn't know that they have the benefit, or if they're too stressed financially, they're probably not going to utilize it. And an employee that's too stressed isn't productive, and then the employer has to have a performance conversation with them. So it's a vicious cycle. It impacts the whole entire life cycle of an employer and an employee.
So Samantha, if I'm an employer and I say I care about the health of my employees and the women that work for me, can I say that with a straight face if I'm not covering infertility benefits?
I mean, that's tough, right? You have to practice what you preach. At least that's how I was raised. So it's a gray answer. Do you care about your employees? It depends, right? We look at when an employer looks at their business, they look at two things. They have people and they have revenue, right? So they're looking at a number and they're looking at a person. And finance and HR, who are usually making the decisions in what benefits are offered, finance sees benefits as a cost center. HR sees benefits as, no, we're helping our employees and we're giving back. So there has to be a middle ground. When we look at that middle ground, what does that middle ground look like? Are we offering rich and comprehensive benefit plans to our employees? Yes or no? The answer should be yes. And then two, how are we financing it? So that's where benefits consultants pull in. We can offer alternative funding methods to where, employers hear fertility benefits and employee benefits and they see dollar signs automatically. It's too expensive, we can't afford it. But that's not necessarily true. There are a lot of different vendors that we partner with, a lot of different vendors that we recommend that employers take advantage of that maybe offer resources that are free to their employees that they didn't even know. So pulling in an expert in the benefit space helps provide different avenues of resources to the employee base.
Well, that's a great segue to Dr. Amy, because some of this is all about how we can use technology to actually make it more effective and less expensive. And I got involved with Oova because I've spent my career in women's health, and I've spent my later career in healthcare at any address. How do we get healthcare out of expensive sick care to health assurance? And Amy and Uva is doing both women's health at any address. So Amy, during the pandemic, I think telemedicine showed us what's possible when necessity really drives innovation. What I'm hearing from Barbara, Dr. Thornton, Samantha is this is necessity. This is necessity for a woman. This is necessity for a man. This is necessity for families. How close are we to meaningful portions of IVF being conducted at home? And how is Uva contributing to that?
Sure. It's a great question, and I think it's actually quite loaded. And Dr. Thornton would love your feedback to this answer as well. But just quickly, a little bit about me. I'm the CEO founder of Oova. I have a pretty heavy science background, PhD in biomedical sciences, focusing on genetics. But the real big onus for Oova is to ensure that women have objective data about their overall health, so they can take their own healthcare in their hands. We don't want to be at the mercy of a medical team to tell us what we can and cannot do. We want to be able to go into our medical team with directed questions and be able to have a two-way conversation. And I think that's something that a lot of women, when they're struggling to get pregnant, don't always have the right questions to ask. They're often walking into those offices quite lost and defeated. So we want to put that empowerment back into women's hands. But to your question, I think telemedicine has really started to shine, obviously through COVID, right? It was a devastating experience, but it did open up, it kind of lifted the hood on our medical situation, and it made telemedicine a lot more important. It also started making it kind of the standard of care. A lot of patients are expecting to get some basic necessity healthcare in the privacy of their own home. And so when you're looking at IVF, one of the things that you can bring in home is the routine monitoring that is being done on a daily basis. Yes, there's ultrasounds that are done. Yes, there's hormone monitoring that's being done. But the reason that a lot of those steps are happening is to time procedures. And where a lot of clinicians should be spending their time is doing those procedures, not necessarily the monitoring appointments. So where Uva started to shine during COVID was being able to take that burden off of clinics to have to do the routine monitoring and instead call the patients in on days that a procedure needed to be done. So we don't need to fill up the waiting rooms with routine visits. Instead, you're really focusing on the treatments that you can provide to your patients.
So Dr. Thorne, let me go to you on this because I think, it's really interesting just listening to Amy in that if we gave everybody access, and let's get back to our magic wand, we give everybody access, it's what we should do. And Samantha has educated us on the health versus finance piece of this, which is real. Um, um, what would you, and there's going to be a lot of changes. I mean, Amy, you mentioned ultrasound. I mean, there are companies that are now, looking at ultrasound at home, et cetera, just like what you're doing with fertility and menopause. Um, what, if you could wave a magic wand, what would get that done outside of your office so that you could see all those patients that now had access that really need the expertise that you have? And what would you never want to have leave the clinical set, the acute clinical setting?
Yeah, so I mean, that's a hard question. I mean, I think certain things that probably could never leave the clinic, at least in an IVF setting, is like in the laboratory. We don't obviously want like eggs and embryo, those have to be in temperature controlled settings. So I think that that's unrealistic. For retrieval is always going to be in an operating room setting where patients can be monitored, and in the lab embryology laboratory is definitely always going to be needed. I think if there was an efficient way that was accurate for doing a lot of like most patients in IVF do come for ultrasounds and blood work multiple times a week to see when they'd be ready for the egg retrieval. And so I think those are cumbersome appointments for the patient. And I think as a physician, towards the end of the retrieval, or not end of the retrieval, end of the cycle, getting closer to the retrieval, they are very critical appointments because it's sometimes is it this day or this day, but early on, most of the time is just making sure the medication dosing is not too high, not too low, that nothing, too surprising is happening. So I would say they're not quite as critical visits as later on. And so, if we had some sort of way to sort of take that out of the clinic, and even for patients monitoring for things like IUI treatment, a lot of times, we're just trying to figure out the right timing for the IUI. And so they typically do monitoring as well, not as intensely as an IVF cycle. But the main point is to know when to do the actual IUI to bring them in for that appointment, which is the more critical appointment. So, those things, if we can accurately get the timing right, not in the clinic setting, I would say are not as, critical to be here.
Yeah, and I guess it's interesting because part of this brings up the larger problem in healthcare. And Amy, you and I have talked about this. It's hard to get somebody to do something when their salary depends upon them not doing it, right?
Mhm.
So, even in pregnancy, I was on the board of a company that was doing obstetric monitoring at home, but a lot of hospital physicians get paid based on having people come to the hospital to get non-stress tests, et cetera. So it almost seems, again, if the four of you ran the system, we could come up with something that would give everybody access, back to Samantha's point, where we could keep the costs in line.
Dr.
So,
Klasko,
go
can I
ahead.
just throw in
Yeah,
something that's kind of
yeah, sure.
interesting? So at Resolve, we work really hard to get insurance coverage for people, and we do that through a number of ways: federal legislation, state, through employers, because our healthcare system is really complicated. A few years ago, after we had gotten some state mandates passed, and it was around the time of the pandemic, I had an embryologist call me. And the embryologists, they run the labs where, everything comes together. And this embryologist said to me, Barb, you need to slow down. I said, excuse me? We need to slow down. We need to slow down getting people access because we're not going to be able to handle all these patients. And I I was kind of blown away. And I said, with all due respect, that's not going to happen. And here's why. I'm a patient advocate, and this is what patients want. You're asking me to solve a problem of how a clinic runs and how a lab runs and how they handle a volume that you currently don't have. In other words, a higher volume. I don't know the first thing about running a clinic or running a lab. I think you need to find smarter people who can do that. But I'm going to keep advocating and filling up those waiting rooms and filling up that if you will, that funnel of patients. But you brought up something about technology and said, hey, what if we wave a magic wand and Barb's secretary of HHS and everyone has coverage tomorrow? There are a lot of Dr. Thornton's colleagues that are going to have a heart attack because they're going to say, we can't handle those patients how we operate today. That's where technology and innovation needs to catch up and kind of be embedded into the system so that we can handle that throughput. But I'm just telling everybody, I'm not slowing down, nor is Resolve. So figure it out and get ready. And by the way, if President Trump comes out with an executive order that gives coverage to people, we're going to have to figure it out.
Yeah,
And
and
I
I
often
want
say, sorry,
go
Steve,
ahead.
I often
Okay.
say that the reason that this is like such a problem is because the incentives between the patient, the provider, and the payer are not aligned.
No,
Until that happens, we're not going to see meaningful change.
Yeah, like I said, it's hard to get somebody to do something when their salary depends upon them not doing it. And so much of, even when I was a health system CEO, and we would talk to people about technology that was, making patients healthier and keeping them at home. I would have my chair of, OBGYN say, yeah, I mean, exactly said, Amy. Well, that's great, but we get paid based on RVUs. So are you going to tell them, or am I going to tell them? So Samantha, this, I mean, here's what I'm hearing, right? Um, I'm hearing that women's health and infertility is a healthcare imperative. I don't think anybody would disagree with that. we have, every employer says, I care about, and I believe most of them do care about my employees and I care about my women employees. Okay, great. We actually have a president for the next whatever years that, whatever else has said, I believe that this should be a mandate. So do we need like a 9/11 commission for infertility care where we get employers and Dr. Thornton and Barbara and Amy and say, because I'm also hearing that if you just open up the floodgates, and don't change anything, people aren't using Oova or other technologies, so, because one of the things I was afraid of is that we weren't really going to be able to come up with any solutions. But could that be a solution where we talk about literally getting some of the country's, major employers and Resolve and Amy and some of her other colleagues and people like Dr. Thornton together and say, how would we be able to give everybody infertility care and do it in a way where we can get that throughput and do it in a way that isn't, quote, breaking the bank?
Short answer, yes. It's like anything that we're proposing. Think about when we were little and we wanted to ask for a later curfew, or we wanted a car and we had to go to our parents and say, I want to stay out later, or I need the new Toyota 4Runner. We had to build a business case for it, right? My parents would come back and say, well, no, you can't have that. So it's the same. Nothing changes if nothing changes. And it starts with education. So it's nonprofits like Resolve, it's companies like Oova, it's doctors like yourself and Dr. Thornton who are educating every specialty within your own practice, and as a benefits consultant myself. So it starts with the education, and then it's the supply and demand. So we can't open the floodgates because that would probably lead to a failed system. But if there's enough people in America demanding the benefit and enough advocating for the change will come with individuals like ourselves who are advocating for it. It's complex, but anything's complex. Look at the trajectory of mental health benefits and how far they've come, right? And it's the same exact thing. People started demanding more, wanting more, and employers started giving it because they couldn't keep their workforce in the door without offering those benefits. So we have to have people educated. We have to have enough people standing up for what they believe in. And it'll come. It's not easy, right? We can't snap our fingers, but that change will eventually come.
So, Samantha, first of all, you were a much more sophisticated kid than I was because I did not do business plans when I asked to stay up an extra hour. So now I know how you got to where you are. But so I went from leading a large health system to now being with all the 28-year-old Stanford dropouts in the technology world. And, and what I hear from my former colleagues, Amy, is look, Steve, you spent 40 years telling us that technology would make our life easier, and, starting with the epidemic, it probably really hasn't, EHRs certainly haven't done that, et cetera. So, you know, we've seen an explosion of infertility and fertility tech startups in recent years. Um, Again, let's talk about Uva first. It's 5 years from now. Where do you see Uva developing beyond what it is today? And then I guess what I'd ask you is, are there any other innovations that you see that would generally improve outcomes and what are some of the things that might be just noise? You don't have to mention, individual company names, but I think there's a lot of technology burnout among both physicians and patients. And then I'd also ask you to talk a little bit about, where does the specter of AI, is it human extinction, is it human seduction come into this whole equation?
Yeah, I mean, it's a really loaded question, so I'll try to piecemeal that a little bit. So the real value of Uva is bringing real-time hormone monitoring over a period of time into the hands of the patient as well as her clinical team, right? So we monitor patients' hormones for 15 to 30 days, depending on what protocol they're on, and we can seamlessly share that data with your clinician if you're working with one. The real value of that is that we have put so much emphasis on clinically validating the data that we are providing. So I think one of the big fallacies for the technology that's coming out is a lot of it is very flashy. A lot of it has like the right buzzwords. A lot of people use AI with everything. But what's the true value add to the consumer and the clinical outcome? Not a lot of folks are putting the emphasis on that. And so we've really been prioritizing ensuring that the data that we're providing is actionable for both the patient and the clinician. And I think within 5 years, while we've been really focused on fertility, we expect that scale to expand outside of fertility and really go across all of women's health, and then possibly even expand beyond that. So I think being having the clinical component of it at the crux of everything that we're doing is the true unique factor of our business model. Um, and then I guess the big thing that I think needs to happen across the board for technology to really be adopted in our medical system is not these like point of care solutions, right? Like we've talked about this quite a bit, that a lot of companies are addressing one aspect of an entire problem. And Dr. Thorne, you talked about like some of the technology that can be taken out, or some of the use cases where technology can step in. But if I give you a hormone monitoring solution today, you still need to have patients come in for ultrasounds, right? So we're not providing you with the full solution. And until we can kind of get some of these technologies to work together and offer you a complete solution, I think the true adoption is not going to happen.
So I'm,
Right, my
yeah,
side.
that's a short, yeah. Um, I'm a consumer, okay, and I'm interested in doing as much of my infertility care at home. And I go on Google and I say, hey, what's a good infertility at home thing? One of the things that impressed me about Oova when I first got involved with you is I went to my chair of OB, who is, as you know, a very, conservative reproductive endocrinologist. And I say, look, I'm talking to, the CEO and founder of this thing called Oova, and they think they can do a lot of this monitoring at home. And he sort of left, yeah, there's all sorts of D2C stuff like that, but I'll test it. And he came back and said, holy, well, he didn't say holy, but something like that, that like this is really just as accurate. Then it got back into the payment model. But how do you've spent so much time validating these things, both for fertility and menopause. And this is like one of those toothpaste 4 out of 5 dentists agree. The doctors at RMA, reproductive endocrinologists get what's different about UVA than maybe another, D2C thing. But how do you get consumers to understand that?
So we take a really unique approach because I don't necessarily believe in this like let's fundraise money and then give it all back to Google and Meta. I've never really jumped onto that bandwagon. It doesn't seem logical business sense to me. But what we do is we do partner with clinics and we let them be kind of our spokespeople, right? Because if you're working with a clinical team and if your doctor says, I want you to monitor your hormones, I want you to use UVA, you are going to Google it. You are more likely to purchase that product versus anything else that you're getting pinged on with ads on Google, right? And that's what we're seeing to be our biggest success right now. So I think it's really about educating clinicians about the value of our technology. We do that by presenting at every medical conference that we can. We've been at the past 5 ASRMs. We just presented at ACOG last week. We've been at the Menopause Society conference. Like we're really trying to make sure that our research is at the forefront and clinicians are listening and they're hearing it and they're adopting it.
Right. So, one of the great things about being a moderator, you get to ask impossible questions. You don't have to answer them, and I think I've done a pretty good job of that so far. So, Barbara, I'm going to give you uh, um, sort of even a maybe more impossible
Come
question,
on,
but an
bring
important
it on,
one.
bring it on, bring it on.
No, not just in infertility, but certainly in infertility. Studies show, women of color and folks that are underinsured have significantly less access to fertility treatments and poorer outcomes. Um, how is Resolve working to reduce these gaps? And what kind of policies could we do to reduce those gaps?
I mean, it goes back to what I said at the beginning, which is insurance coverage for everybody. So we want to see comprehensive, effective insurance for everyone. And so we believe that that's really the equalizer for everybody in getting diagnosis and care that they need. Um, honestly, at Resolve, we do believe that your zip code does impact your care. And why do we have to live in a country like that? Why does it look, nobody when they're young is going to be like, you know what, I'm going to have infertility, so I'm going to move to a really good mandated state. I'm going to move to Massachusetts or Illinois or Maryland because I'm sure that I'll have, nobody knows that. Nobody builds their life and their career and everything around, a state mandate. And we've also heard, as hard as I worked to get that state mandate in New York, do you know how many trips I made to Albany, Dr. Thornton? I know it doesn't cover everybody, right? That's the complicated nature of healthcare in our country. And we hear this all the time. We're like, you talk about this great mandate in New York, Barb, but it's not covering everybody. Wouldn't it be amazing if every resident of New York who needed care got it, regardless of their skin color or where they lived or their income, right? So that's how we are trying to solve for it, is let's equalize the care, and then go from there.
So, Dr. Thorne, let me ask you this in practice. So the two things we just heard from Amy and Barbara about the health infertility disparities, and Amy about the technology explosions. In your practice in both of those areas, first of all, how important is cultural competence in when you're seeing patients? The differences between people of different cultures as it relates to infertility care, and then. On the Amy side, how is the tech explosion changing patient expectations?
Yep. So, and definitely agree with Barb's statement. I know Barb well from advocacy. It's amazing how many of our politicians in New York sometimes are like, "What? You mean it doesn't cover everybody in our state still?" So, definitely harping in on certain zip code matters, and unfortunately, some people live more in certain zip codes with coverage. And so I don't know if it would necessarily be an ethnical background, but it really dictates care for a lot of patients. I would say from a cultural point of view, I think different cultures sometimes view infertility differently, and how their family members may view and how they feel that others may view them. And some people are, and it's not always, some people are very an open book no matter what their cultural background is. But there are some people where in their culture it is considered something very negative. They feel very ashamed, and they feel ashamed to seek out care when they're having trouble getting pregnant. Even if they had access, they may not access it because they don't want people to know, and they think of it as it's their fault. A lot of individuals and couples with infertility think of it not as a disease, and a lot of it's probably as society we haven't placed it as a disease, even though it is. A lot of people think I must have done something wrong. I'm not doing something right. I wasn't healthy. I didn't do all the things I was supposed to. So it's a self-blame thing, and it's why nobody would say, okay, I hurt my knee. It's or, I have high blood pressure. It's my fault. I did something. It's just very different for infertility. So different cultures definitely handle it in different ways. And what was your second question
The
about?
question was, are patients coming to you with different technology expectations? Are they coming to you, having gone on ChatGPT or Claude and saying, how come you're not doing this, or how come, AI is
Yeah.
guiding your, the needle when you do
It's
your
very much, it's very much a mix. It's shocking to me how majority of women coming in still don't know anything about their reproductive care. And I can't tell you, every day I feel like I'm a teacher and an educator, and I have pretty much at least once a day a woman tell me, my whole life everyone told me how not to get pregnant. I never even knew it could be hard to get pregnant. I never even knew what I was supposed to do once I wanted to try to get pregnant. And it is quite shocking in 2025 that is something I hear every single day. So it's like you have the one extreme of people who truly know nothing. They don't know if they ovulate. They don't know if they have regular cycles, when their ovulation window would be. They don't know how to, like, when they should be timing intercourse. They don't know anything beyond, like, I'm supposed to take a prenatal vitamin. And a lot of women don't even know. I have people who don't get their period like once every 3 to 4 months, and they think that that's normal, or women who have severe pain and they can't get out of bed and they think that that's normal because it wasn't talked about enough, and there wasn't that education component. And then on the flip side, you do have the people who have Googled everything, and you always have to be careful because some of stuff on Google is true and some of it is not. And so it is a lot of myth debusting of, okay, this is actually valid. No, this is not actually valid. And kind of going through and educating patients on what we know and what we don't know. And I think that really, to me as a physician in this field, the hardest part is there is so much we still don't know in the infertility realm of why certain diseases happen, or we so many people with unexplained infertility, what is going on, and having to say it's okay that we don't know. And unfortunately, this test sounds great. It sounds like it would solve all the problems, but there is no medical evidence or background that it actually improves anything or that is going to help anybody. But it's people want an answer and want a reason. And so sometimes that we don't have those answers is almost harder. And so people go searching for things that unfortunately sometimes there are no medical validity behind.
Yeah, although I do think, I think the patient education side, the ChatGPT, OpenAI, and others are a bit of a game changer. I mean, I remember, 10 or 15 years ago, if I told somebody that I had lupus during pregnancy and they said, oh, I Googled and St. John's Wort helps or something, like I could just knee jerk and say, look, if you Googled it, it doesn't mean anything. Now, if I say that, they might say, oh, that's interesting because you must disagree with the chair of OB from University of California, San Francisco, who just published what I said in the New England Journal of Medicine. Or didn't you read that, Dr. Klasko? So I think we are going to get into a little bit of a different kind of, educated patient piece. Samantha, I want to go back to the employer piece, and both on your role at SHRM, but also in your podcasting. Yeah, so how where are we at with benefits for people going through infertility treatment? I mean, there's the being able to have infertility treatment, but there's got to be productivity issues. There's got to be, oh, I'm sorry, I have to. They probably have managers or whatever that aren't as sympathetic. You know, are, have you seen a change in employers? Basically saying, hey, again, if you have cancer, people would say, hey, look, we have to let Steve, get his treatments and stuff. But, are we at the point where people look at the same way with, Samantha's going through an infertility treatment, and we're not going to hassle her, about, getting ultrasounds or going to the office?
That's a great question, Dr. Klasko. So in 2024, 42% of US-based employers offered fertility benefits. That's up from 40% the year before. So we're making small, chipping away at the stone small in small pieces. I would love to see that above 50% in the next couple of years. We are having employees demand more benefits, as I mentioned earlier, and employers are becoming more sensitive to it. For instance, look at parental leave benefits. Those have changed drastically, either mandated by states or different leave actions that have gone into place. But employers are opening their eyes. And why are they opening their eyes and being more sensitive to offering fertility benefits or parental leave benefits? It's because they're struggling to keep their workforce, right? We have one of the biggest labor shortages in today in America than we've ever seen before. And so it's going back to the data. And Amy, obviously, you can speak a lot to the technology and the data, but what does our retention look like as an employer brand? What does our productivity look like? Because those are all tied into does my employee believe in me? Do we believe in the employees? And do they feel comfortable to take time off to go see a mental health provider or a fertility specialist? So it goes back to the data. There are ways to measure that, and that's what we advise employers. We also advise employers to ask your employees what they want. Survey them. Don't assume that they want a particular benefit. Don't assume that they don't want a particular benefit. So actually listen to what your employees need and want.
Great. All right. So we have about 15 minutes left. This is like double Jeopardy. This is going to be a lightning round. And I'm just, so I'd like the answers to be, a minute or less. And I'll just go in order of alphabetical order of first name and then do it different each time. So first question is, I've talked a lot during this time, and ask you folks to wave a magic wand, whether it's with Resolve or as a clinician or as a benefits manager. If you could wave that magic wand and change one thing about fertility care in America today, Amy, what would that be?
Dr. Thorne, you kind of stole my answer. I think it's really educating women about what their fertility and their reproductive system and their menstrual cycle truly means, and how important it is to understand your hormonal patterns to take your healthcare into your own hands.
Barbara?
No surprise. Everybody has insurance coverage. They don't even think about it. They don't have to advocate. They don't have to fight for it. They don't have to ask for it. If you get in I don't know, anything else in your health, in your body, we take care of. We don't for this. And I want to see a world where nobody even ever has to advocate for this kind of coverage again.
Dr. Thornton?
It's a hard one. I think as a physician, IVF is our best chance of success, but there's still so many people that require multiple cycles to be successful. So I think if we can even get our success rates higher and more research and trying to figure out those gaps of how we can get more healthy embryos and get embryo implantation rates even higher than they are, I think that would make a huge difference.
Kimberly, where are we at today in 2025 as far as, the percentage of people that go through, let's say, 3 IVF cycles that are able to achieve a viable pregnancy? I know that's a tough question because people.
Yeah, I mean, it's very age based. So like a genetically tested euploid embryo, I would say on average in the United States, pending lab and grading is usually somewhere between a 50 to 70% chance of a live birth per embryo. But somebody under age 35 is more likely to get a healthy embryo, maybe potentially more than one healthy embryo in a single IVF cycle. While when you have somebody doing IVF in their early 40s, where it can be anywhere between 70 to 90% of embryos are genetically abnormal, then it is almost always more than one cycle to get that success. And then even those perfect healthy embryos, 30% of the time don't implant. So we don't, that even if we could figure out why sometimes even genetically healthy embryos are not implanting, is there other factors that we don't know to test for at this point in time, would be big changes in the field.
Samantha, I'm leaving the magic wand with you. What's one thing about fertility care in America that you would change that hasn't been
With my
mentioned?
magic wand, I'll give you two. One is education earlier and for not just women. It's important for those who identify as other genders to be educated as well because it contributes to the future planning. And then two would be inclusive access to all of those people.
Great.
There's
All
my
right,
wand.
Barbara, that's great. No, that's fine. So, Barbara, what's an important trend of fertility care that maybe isn't getting enough attention?
I think when that question is asked, you always think of something positive. And
Right.
because I'm an advocate and I lay awake at night thinking about the disasters that could befall us, I'm gonna go in a different direction with this. So trend may be a little, I might be pushing it. Um,
Right.
I am very, very concerned about potential accidents. We've seen labs where they've had tank failures. I was very, very involved in the Alabama Supreme Court issue in February 2024, which, let's remind ourselves, started because somebody got access to the tanks and opened the tanks and destroyed the embryos. So my lay awake at night trend that I'm very concerned about is that there is some around the corner, some potential catastrophe, accident, whatever, that is going to really elevate those that want to shut IVF down in a way that they're going to be heard. And we're going to have a regulatory mess on our hands. So that is something that I hope it never comes true, but as long as I keep getting asked these kinds of questions, I'm going to say that.
That's important. Dr. Thornton, what trend or threat isn't getting enough attention?
It's also hard. I feel like a lot of the trends in fertility are sometimes not positive. And so I think I would say in a positive center, which I wish not enough, or I think not enough people talk about or focus on, is the mental health aspect of it, and getting counseling and having those extra supports during treatment, and not being afraid to, or not feeling ashamed or being afraid to talk about journey and getting help when needed.
And Samantha, what about you?
Trend that is not that we don't have enough of would be education. There's not enough people educated at any point in their life and journey. And positively, or I guess not positively, but what needs to change is the access that patients and their families have to the care.
I mean, what trend in your world isn't getting enough attention?
Well, I think there's a really high rate of unexplained infertility, and a lot of that has to do with the lack of proper data and studies. And if we can start to chip away at that by diagnosing women with health issues earlier that I believe go undiagnosed well before they start trying to get pregnant, it will hopefully enable them to get proper care earlier and then hopefully lead to much more positive outcomes when they are trying to get pregnant.
All right, so I have one final question. Okay, we're going into the future. Just complete this sentence for me, Dr. Thornton. By 2030, IVF and infertility care will be
Considered medically essential treatments.
Samantha. By
Offered
2030, IVF will be
offered to all Americans.
Mhm, mhm.
Amy.
IVF will be a standard of care that is not a question.
Barbara.
Can I just say all of the above? Because that would be amazing. I'm going to say in 2030, IVF is legal and protected in all 50 states.
So, by the way, this has been really, really great. I wish we could wave a magic wand and you were all in the positions that I gave you as Secretary of HHS and policymakers. And I do think, potentially trying to get this 9/11 commission of people that care about this, or we say that they care about this, which should be everybody in the country, would be good because there are solutions, and in many ways you've brought them up. I just want to sort of leave you with a few quotes because as by far the oldest of this group, um, my first startup enterprise was called Spirit of Women in 1983. And so we've made some progress in that Spirit of Women obviously is pre-computers. It was just going to hospitals and having them think about women as women's health and not, in fact, our stealth name was NJRO, not just reproductive organs, because before 1983 and before Spirit of Women, hospitals had the uterus center and the breast center and the ovary center. And, what all we did was say, hey, women are actually like whole human beings. So we've come some way. That's the real positive side. The negative side, and I like to use this quote from Jason Kidd, who was a NBA basketball player who went to the Dallas Mavericks. They were 24 and 52. He said, I'm going to turn this team around 360 degrees. On the other side, we've been talking about infertility care for families being a right, being health, even back in the 80s and 90s, even and before we had a lot of things that you now use, Dr. Thornton, but just being able to do that. So we do have this interesting contradiction. And I think what's exciting is um, what we've heard tonight is both the incredible promise and the profound challenges facing fertility medicine. And each of you brings some of that to the table. We have amazing technology. Thank you, Amy, that's revolutionizing how we understand and treat infertility. We have employers. Thank you, Samantha, stepping up with benefits that even though we're not there, but would have been unimaginable back when we were starting Spirit of Women. We have advocacy organizations. Thank you, Barbara, that are just, dogs on a bone fighting for policies that could truly democratize access to fertility care. And we have literally fantastic clinicians. I often say, when I look at IVF technology, we have Star Wars technology sort of in a Fred Flintstone policy world of infertility. Um, and, obviously the political landscape similarly is very contradictory, right? I mean, we've talked about that. Thank you, President Trump, for saying this on the campaign trail. Hopefully we will hear from him and the folks that matter that the policies that have been drafted actually happen because they're all there, ready for him to announce. And and I think that were that to happen, it would force the kind of discussions, Samantha, that you've brought up, with employers of, how do we do this in a way that A doesn't, you know, that doesn't break the quote financial system that allows Kimberly and her practice to, see that many more people by using technologies that Amy has and having Barbara and Resolve spend more time on educating patients what's available instead of trying to, have lawmakers recognize that infertility is right. So that's my dream. I don't think, and I actually think it's a chance that that dream will become a reality and we can all wave our magic wands and not have them be so magic. So, Amy, Barbara, Kimberly, Samantha, thank you. This has been a lot of fun for me. I think it'll be a lot of fun for our listeners and really appreciate everything you're doing every day. Thanks.
Thank you.
Thank
Thank
you.
you.